Hello, everyone. Thank you for joining us tonight. We have a really exciting webinar for you. I am Jackie Cancier, Executive Director of the National Council on Severe Autism. We have tonight the Child Mind Institute, and they are going to be discussing understanding the development, behavior, and psychiatry of children and adolescents with profound autism. With the very esteemed Cynthia Martin, Stephanie Ruggiero, and Jason Sarte with us tonight. Just a little bit of housekeeping. We do have a Q&A, so whenever you have any questions, just go ahead and type your questions there. It's a lot easier for us to find them than in the chat. So type your questions in the Q&A, and we will have that live Q&A following the webinar. But feel free to use the chat for your general discussion during the webinar. And with that, I will turn it over to our guests. Thank you.
Thank you for such a warm welcome, and good evening, everyone. Thanks for joining us tonight. We are all very passionate about autism, so looking forward to providing this webinar and answering your questions. So we are coming from the Child Mind Institute. The Child Mind Institute, we are a leading national nonprofit. Our mission is to transform the lives of children and families who are struggling with mental health, developmental, and learning disorders. We do have three major pillars to our work, including science and research, our clinical care, and then our public education. So what we're going to be talking about this evening as it relates to profound autism is starting with an introduction to autism and the trajectories of development. We're going to talk about how to support autistic children who have aggressive or self-injurious behavior, as well as how to treat co-occurring psychopathology. And then we'll have time at the end for questions as well as discussion. So we know that autism is a very complex diagnosis. This is a disorder that kind of came into our repertoire in the 1940s, but it really wasn't until the 1980s that we started formally diagnosing autism based on the Diagnostic and Statistical Classification Manual. So as the autism diagnosis has come in to the professional and clinical spectrum, we've been able to funnel more research into autism. We've been able to learn a lot more about the complexity and the heterogeneity of what makes up autism spectrum disorders. So we know that an individual, to get a diagnosis of autism or to be presenting with autism, they do need to have these two core areas of co-occurring challenges where there are deficits in their social communication, social understanding, combined with the presence of restricted and repetitive patterns of behavior. Simultaneously, we know that how these symptoms present in one child is going to be really variable. So when we think about autism spectrum disorder or autism, I almost think of it as more of autisms. So we see hundreds of different variations in phenotypes of autism. And the reason that autism can be so variable in its presentation is because we're going to have children with one single diagnosis who present with significant variations in what their language level is, ranging from children who are non-speaking or minimally verbal up to children who have advanced verbal skills. When children with autism can have co-occurring cognitive or intellectual challenges, some reaching the degree of an intellectual disability or an intellectual disorder. Some children have more significant impairments in the verbal aspect of intellectual functioning, but have really intact and highly developed nonverbal intellectual skills. Those two different cognitive profiles and language profiles in combination with variations in autism symptoms will significantly vary and change how that child presents on a day-to-day basis. We also know that there can be significant differences in a child's adaptive functioning. So adaptive functioning is how much are they doing independently with or without support in their day-to-day. So do they need support in terms of just monitoring? Do they need support in terms of full help in completing those day-to-day types of activities like toileting, showering, other aspects of self-care and hygiene, feeding? Can they be out in the community in a safe way and understand nuances in safety related types of behaviors in terms of places as well as people? Then we know that kids with autism have high rates of comorbidities or co-occurring conditions. So you can have autism and you can have autism on its own, or what's more likely is you have autism with something else. So you can have autism with co-occurring disorders of attention, mood, anxiety, etc. We also know that children with autism have higher rates of medical conditions. So, when we're thinking about children who have profound autism, typically those are children who have a significant level of symptoms across these core areas of autism spectrum disorder symptoms, as well as significant needs related to their language functioning and their intellectual functioning. When then we look at those kids and rates of medical conditions, we see that there are really high rates of co-occurring medical conditions. We also know that when kids have medical conditions and they have difficulty with language and communication, or difficulty with thinking and processing and reasoning their intellectual skills, they have a really hard time being able to communicate what doesn't feel right and what is going on with them medically. So they need very close and careful monitoring by a full team in order to really best meet the complexity of needs in this presentation. When we look at symptoms of autism over time, we do know that most of the children who we are diagnosing with autism in the really early years, so we are reliably detecting autism now in children who have those full detectable symptoms between ages 1 and 2. And then we're able, in the longitudinal research, we're able to follow those kids over time. And what's been found in the longitudinal studies that have followed toddlers with autism over time is that there's typically 4 main profiles of children who emerge, where we see some children with persistently high levels of autism symptoms. They're high when they're toddlers, and they tend to stay really high across time. We have another group that tends to show a more persistently moderate degree of symptoms. And then we have 2 different profiles where we see an increase in symptoms and a worsening of symptoms. Now, an improving of symptoms and a worsening of symptoms. So on the lower left-hand side, the worsening group, we see they have a lower level of symptoms when they are toddlers, and then those symptoms of autism tend to increase over time. We see another group of children who have higher symptoms of toddlers, and then those symptoms tend to improve over time. When we're talking about this, though, we're really only talking about core symptoms of autism. We're not talking about all of these other factors that come into play here. So when we're thinking about a child who might show improving autism symptoms, children who have profound autism, so meaning children who have a pretty high level of autism symptoms, meaning that it does impact their language functioning, it impacts their cognitive skills, they can still show improvements in some of their core autism symptoms over time. Now, we know that the rates of comorbidities are very high for children who have what is being designated as the characterization of children with a more profound autism. Your primary secondary diagnosis that is most likely going to be prevalent is having an intellectual disability or a language disorder associated with the autism presentation. We do know, as I was mentioning previously, that children with a more profound profile of autism tend to have higher rates of co-occurring medical conditions. They may also have higher rates of known genetic etiological factors that can be contributing to the autism diagnosis. It's still the minority of kids with autism who have known genetic causes, but we are getting better at being able to identify and recognize some of those genetic markers and genetic causes for autism. And when those are present, it often tends to be the children who have the more profound presentation of autism. We know that the way a child accesses an educational curriculum is going to likely be very impacted by the presence of autism, especially when there's co-occurring diagnoses of intellectual or language disorders. It's also, there are very high rates of attention deficit hyperactivity disorder. So this is where we want to be thinking about how a child's intellectual level, cognitive developmental level comes into play with attention level. And if we have a child who is, let's say, chronologically 7 or 8, and they have a pronounced autism presentation combined with intellectual disability, we want to get an idea of where they are in terms of their developmental skills. So if they are 7 or 8 chronologically, but they're more like 3 or 4 developmentally, then we want to be thinking about those potential ADHD related symptoms in the context of development. So we would kind of benchmark where we expect their attention, their impulsivity, their impulse control, their regulation related to physical movements to be more at that level commensurate with their developmental functioning, which could be more at a 3 or 4 year old level. We also know that children with more profound presentations of autism can have high rates of anxiety disorders. It can be really difficult to navigate a world that is not set up for you. So, of course, you are going to feel scared and anxious more than other people around you because the way you're processing the world and where your attention is focused on and processing and how things are coming at you is going to be different than somebody who doesn't have your same developmental presentation. So we do see lots of anxiety. And then what can be one of the most challenging aspects of functioning for children with this profile is when there's co-occurring disruptive or problem behaviors. Those mean behaviors that are difficult for parents, teachers, community helpers to be able to navigate and support a child through. We do know that children who have language and cognitive delays associated with their autism presentation, they have much higher rates of disruptive and problem behaviors. And we know that we can do things to address those. One, by looking at what are some of the co-occurring conditions that might be leading to these problem behaviors. So does the child have an underlying medical condition? Is there untreated mood dysregulation or anxiety? Is their learning, their academic curriculum not at the level of where their learning really is, where learning and development is? Are we not appropriately scaffolding that for them? And you may see behavior that comes up as a consequence to that. So we want to understand what all those co-occurring conditions are, treat those so that then we can really identify where do specific types of problem behaviors arise. And we call them problem behaviors because they're creating a problem for the child. They're creating a problem for the child in being able to access and navigate environments at the level that they are capable of. And so those are behaviors like aggression, physical aggression to themselves or others, any type of self-injurious behavior that could be very harmful actually to them. Those are behaviors that once we've identified these other potential co-occurring symptoms, we want to make sure that we treat. Similarly, back to the medical piece, we can see that some kids with underlying medical conditions might present with what looks like behavioral challenges when they they might have untreated constipation and stool withholding, or they might have, which would affect their bowels and their stomach. They might have an injury. They could have a very high pain tolerance where there was an injury that they didn't communicate about or were not able to communicate about. And now that injury has led to some other medical condition. And now you're seeing this abrupt change in a child's behavior. So when we're thinking about treating disruptive behavior, we never go to the behavior first, but we want to get a really good, clear evaluation and picture of the child so that we can create a good roadmap forward and best helping them. So one of the things that I often think of when I'm seeing parents of children with a more profound presentation of autism is that parents are put in this position where they have to walk down a path that is not well carved. There's often not a clear path for them. There can be other paths where they might kind of start down, but then it ends up not being the right one for their child. And so they at some point have to diverge into a path that is not really clearly carved yet for them. And so what we have to do is build a team around that family and that child so that we can understand what that individual child needs and walk that path with the family. Because that is, if you think about having to walk into a forest completely on your own with no guide, that's really scary. And we don't always know the exact right perfect path, but there's a lot that we do know that we can help shine some light on that and help create that path and carve that path out together with the family. So when we're thinking about getting a developmental evaluation for a child who has a more profound profile of autism, we want to be able to construct a profile of strengths and weaknesses. So really be able to understand what that child's cognitive profile is like. Where are they developmentally? Take out their chronological age and let's see developmentally where are the strengths and weaknesses, because that helps us to know where to benchmark all of these other possible co-occurring symptoms in light of. We want to identify the areas that are the most challenging for them developmentally, as well as the strengths, so that we can use the strengths to help bolster up the areas that are more challenging. We do have to establish an accurate primary diagnosis, so we need to have a good characterization of what that individual child's autism symptoms are, because one child with a more profound presentation of autism will present very differently from another, even though we see some of these shared characteristics. And then how those core symptoms of autism present are going to look very different in combination with those co-occurring conditions that I reviewed a couple slides prior. So we need to identify what co-occurring symptoms are present and to what degree those are present and how are they interacting with the core symptoms of autism. We need to use that information to then develop a comprehensive intervention plan that is going to span across every aspect of that child's life. That includes home, school, their outpatient-based services, as well as community settings and how they navigate the community. We need to use assessment to also get a baseline so that we can monitor their response to treatment over time, as well as their developmental trajectory. We kind of think about it as like when you're going to your pediatricians to see where your child is on the curve for height and weight and BMI. We're kind of doing the same thing for development, where, in typical development, we expect a certain course or trajectory. We know that a child with a profound profile of autism might not be on that same developmental trajectory, but they will be on their own developmental trajectory. And so we do want to help that child inch forward and make progress along their trajectory. And we do know that that is something that we can do, and we can use our assessment tools to help us really identify where to intervene for that child and help build up those strengths to help them have the most optimal course of their developmental trajectory. It also helps us to really understand the child in a way that we can establish a relationship with the family to help them really appropriately navigate different systems of care and education. So as parents who are watching this, you want to have people on your team who know your child so well that can say, yes, this is something that needs to be added in for them at school. Or, something else comes and it's like, oh, should we try that? And it's like, no, that's probably not going to be that really worth the time and the investment for your child based on this profile. So you really want to have a relationship with a care team that can really comprehensively understand your child to help you navigate all these millions of systems that you're going to be walking down as you're walking that path with your child. And then you're never going to have one single person who treats everything in a child who has autism, and definitely you're not going to have one person in a child who has profound autism. So you are going to need a provider who is going to know what they don't know and is going to know when and how to refer you. And to be able to create that team of, do you need neurology, genetics, feeding specialists, psychiatry, behavioral specialists, etc. So what we're doing through an evaluation is we're getting all of this information in that individual child, and then using that information to help create this roadmap. And that roadmap helps us take the child from the point of that initial diagnosis, which could be as early as 1 or 2 years old, and helps guide and provide that anticipatory guidance all the way until adulthood and beyond. So we have different key areas that we're often really prioritizing and focusing on in different points in time. And one of the things throughout all of these that we're really looking for is when possible co-occurring conditions could emerge. And one of the things that we see in the really young kids is when we have young kids who, with autism, a more profound presentation, if they are having difficulty with behavior and emotion regulation, we know we want that to be one of our core areas of of intervention in the early ages, because we know that children with that profile often don't just outgrow those behavioral challenges with age. So things like tantrums in a 2-year-old or a 3-year-old are very common. But a child who has autism and a profound presentation of autism is unlikely to just outgrow those tantrums as a function of age, like some other children might. So that's where we really want to be intervening, in addition to building up all of these other developmental skills and skills that are really important to a child's quality of life. We want to target all those areas that the child is not learning naturally and help them learn those skills. So things like their language and communication, cognitive skills, adaptive skills, and their behavioral regulation skills. And then we continue to identify different points in time when we know that those co-occurring conditions of disorders of attention, mood, or anxiety have higher possible chances of coming online for a child. So now I'll turn it over to Stephanie to talk about how we support behavior.
So one of the more common problem behaviors seen in profound autism is self-injurious behaviors, or SIB, which refers to aggressive behaviors that an individual directs towards themselves and that has the potential to result in physical injury. This can include things like head banging, either one's hand to their head or head to an object, biting oneself, hitting oneself, either one's body part against oneself or yourself against a hard object, also scratching or skin picking, poking or pressing into one's eye or gouging at one's eye. And research has found the prevalence of occurrence of self-injurious behaviors in individuals with autism ranges anywhere from 33 to 71%. And self-injurious behavior is more common among individuals with ASD that have comorbid intellectual disabilities and increased severity and quantity of autistic characteristics, so a more profound presentation of autism. And research has also found that self-injurious behaviors are likely to persist in upwards of 80% of individuals with autism over a 3-year period. So as Cynthia just mentioned, it's not likely the behaviors will just go away, but that they're likely to continue. And why this is really important is because the behaviors can lead to, oh, thank you. It probably was when we switched off. Oh, it's going in the wrong direction. Here we go. Thank you. And that's because self-injurious behaviors can be associated with serious health conditions. So it can lead to lacerations, contusions, sometimes fractures, or even concussions that may need to be hospitalized, or if it's serious enough, could lead to death. And it is one of the primary causes for ER visits among individuals with autism. Another common behavior seen in profound autism is physical aggression, and this refers to behavior that is threatening or likely to cause harm to another person, either through making physical contact with that person, using one's body or an object. So hitting, biting, hair pulling, headbutting, throwing objects, and research has found that the prevalence of aggression in individuals with ASD ranges from 17 to about 56%, and it's one of the more common behaviors among individuals with ASD in comparison to their typically developing peers. And really why it's so important that we look into physical aggression among individuals with autism is because when individuals with autism exhibit aggression, they're going to be removed from their classrooms, they're going to be excluded from certain services, there's stress and strain on caregivers because it's difficult to manage, and it might lead to institutionalization because people are just not sure how to manage it and they're doing it for safety reasons. So given the impact of aggression and self-injurious behavior on individuals with more profound autism's health functioning within the school and community, it's really essential that these behaviors are treated. And when these behaviors are treated, we really want to kind of identify we have this behavior, we know what it is. Now, what's the whys and what's of it, so that we can develop an appropriate treatment plan. And so that's done through a systematic data collection process. I specifically conduct functional behavior analysis, or FBA, and that's a process of gathering data to determine kind of what consequences are maintaining that behavior for someone. And that could be access to social attention, access to preferred items or activities, removing demands or unpleasant stimuli, or access to sensory stimuli that is preferable. And as part of the FBA, I have listed on here some steps a provider might take, or at least these are the ones I take in treatment. So always starting with a review of records. We want to know the history of the behavior, previous treatments attempted, like Cynthia said, getting that more global picture of any previous medical diagnoses or anything else, their educational history, everything that's going on. We do extensive interviews. So we want to interview with parents, teachers, other relevant caregivers to get different perspectives on the behavior, so we can operationally define the behavior, really name what that behavior looks like, the frequency of it, how often it's happening, what conditions do we see the behavior during, when don't we see the behavior, and how is behavior currently being managed. And then we do observations. So we try to conduct it in such a way that we're observing someone in their natural environment without really interfering with their normal activities. So more like being a fly on the wall. And so that's done through a naturalistic observation. And generally with more severe behaviors or problem behaviors, we will see those during this type of observation. The final step of the evaluation process is a functional analysis, or an FA, which we're going to look at on this other slide, which just gives some more details about it. So the FA is an experimental assessment where we're actually manipulating their environment. So it's different than the naturalistic observation, because what we're trying to do is isolate and observe how someone's behavior changes in response to specific conditions that we are using. And this is really the most precise way to determine the function or purpose of a behavior. So during this FA, 4 conditions are completed ideally by a parent or caregiver, but can be done by the provider if needed. And really, we want to know kind of what is maintaining this behavior. So the conditions that are done is a tangible condition. So in this, we restrict access to a highly preferred tangible or some item that is really preferred to the individual, and we only provide that access back to them if the problem behavior occurs. So if they become physically aggressive, they get access to it, and then we remove it again. If they're physically aggressive again, they get it back to it. This is only to determine the function. This is not treatment. So that I'm just stressing that, because people might be like, why would you do that? So it is really to see, like, is this going to come up that is the reason that behavior is occurring most. In an attention condition, you withdraw your attention and only provide that attention if a problem behavior occurs. So if the individual begins to engage in self-injurious behavior, it's a quick attention. Don't do that, you'll hurt yourself. You withdraw it again. If the self-injury occurs again, you give your attention. In a demand condition, you provide demands. So whether that's fold the shirt, write your name, depending what kind of demands are ones that, when we did our interview, are ones likely to lead to behaviors, or the ones we will do during the FA. And we withdraw the demand. So take it away and say, okay, don't worry about it, wait, and then represent it. And so when that problem behavior occurs, it gets removed. And then we have one last one, which is more of our control, just to make sure that we are comparing it against things. And so in this one, it is a play or control condition, because really we're setting it up to be the individual's ideal world. They get access to anything and everything they want. They get the person who's in there's full attention. There's no demands or non-preferred stimuli put on them, and we're not disturbing anything they're doing. We're allowing them to engage any ritualistic behaviors. And so typically what we want is not to see any behaviors in that. And then we can compare the other 3 conditions against that one to see which one is the potential function of the behavior, which can be one or more. So then we can create targeted targeted interventions that really address the root cause of the behavior to lead to more effective and sustainable outcomes. So when we then know what the potential function is, there are 4 functions of behavior or causes of behavior, and a behavior can serve one or more of these. So there is a sensory function for behavior. And so if a behavior serves a sensory function, it's because the individual has learned over time that engaging in this behavior at some point resulted in an internal sensation that felt good, kind of expended excess energy they had when maybe they were excited, helped them calm down, or even helped relieve some discomfort they might have been feeling. And due to that inherent pleasure, of the sensations or relief from the discomfort they were feeling, they continue to engage in the behavior. For an escape behavior, this typically occurs after a non-preferred, after a non-preferred task or activity occurs, or like a boring or aversive stimuli is presented. And so when that happens, the demand is taken away. And so that behavior occurs more to ensure that that access to the non-preferred or aversive setting or situation doesn't continue. For behaviors that serve an attention function, it is to gain either positive praise or recognition, sometimes even negative attention from someone who has withdrawn their attention or at times divided their attention, right? Someone's on the phone or talking to somebody else, but in the room with them. And so getting that attention from another individual or social interaction. And then the last function is a tangible function. So a behavior that serves a tangible function allows an individual to gain access to tangible items, activities, privileges, or preferred ways of doing things. So, just to give an example of some of the behaviors we've been talking about, this is an example utilizing an antecedent behavior consequence data. So on here, we have a parent tells a child they can't have their iPad right now. That's what's happening before the behavior. The behavior itself is the child cries, repeatedly hits their own head with their fist. And so parent tells the child that they can have their iPad and gives it to them. In this instance, the behavior is serving a tangible function because it's allowing the child to gain access to the iPad. Another example is this one, in which a parent tells a child it's time to go in the shower, instructs them to go get into the bath. In response to that demand, the child refuses, gets aggressive towards the parent, hits, kicks, pushes to try to get out of the hallway. Because of the behavior, the parent doesn't continue with the demand to bathe. And so for this behavior, it's serving an escape function because the child is able to escape the demand to take a bath, or potentially just delays it until parent can get them in there, but it's allowing them to escape that non-preferred activity of bathing. So now, once we've done this evaluation, we have a better idea of the function or purpose behind the behaviors. We start to treat the behaviors. And typically we want to start with indirect treatment options, which are more behavior modification strategies aimed at modifying the individual's environment or influencing the people around the individual with the problem behavior, rather than directly working with the individual themselves. And so these strategies are called antecedent-based strategies because they're proactive, and they aim to change the environment before a behavior occurs. And really what they're doing is trying to create situations or circumstances where more desirable behaviors are likely to happen and reduce situations where problem behaviors will happen. So the first thing we want to do is we want to adjust the physical environment to ensure safety. So we want to make sure that the environment is free from stimuli that can trigger self-injury or aggression, remove sharp objects that can be used for self-injury. We want to make sure there's no objects that could be used to hurt others, sports equipment, sharp objects, heavy items. We also want to create a calm and sensory-friendly environment if sensory overload can contribute to self-injurious behaviors or physical aggression. aggression. We want to try utilizing visual supports like schedules, timers, choice boards, social stories, because these help reduce stress and anxiety associated with upcoming transitions. They explain the components of what someone's being asked to do so it doesn't feel as daunting. It prepares people for upcoming situations that could trigger problem behaviors. And we really want, whenever possible, to allow individuals to have some control over their activities by providing choices to really help the frustration that they might be experiencing. So do you want to do this activity first or that one? Giving that autonomy when we can. And we also want to manipulate the way we give demands. So we want to mix simple high compliance demands. So these would be demands that the individual is likely to comply with you give, with more difficult, lower compliance demands. So demands that aren't as usually likely for them to follow through with. So that way there is a combination of them. And we want to only give commands when necessary. So only things that really are important that get done and need to happen. And we also want to change how we're giving those commands. So we want to be direct, say what we want them to do. Please go put your code away. We don't want to ask, because if we're asking, then there's an option for them not to do it. So we want to avoid like, could you, can you, or let's commands. We also want to be specific, making sure there's no question for the individual of what is it I'm being asked to do. We want to make sure we're always positive when we're giving a command, meaning we want to tell them what to do instead of what not to do. Please use walking feet instead of stop running. And we want to give commands one at a time because it's just easier to remember and it gives you more opportunities to praise the positive behaviors. So once we have made some of those antecedent modifications, then we turn to more direct treatment options, and this will involve directly working with the individual. And so there's two main types of treatment approaches that we utilize when addressing severe behaviors, either behavior modification or function-based treatments. With behavior modification, what we're really focusing on is changing a behavior through eliminating the maladaptive or problem behavior, and this is through reinforcing the use of more appropriate alternative behaviors. In function-based treatment, what we're doing is really focusing on the why a behavior is happening. And what we want to do is teach or reinforce more socially appropriate behaviors to get that individual's needs met without them having to engage in a problem behavior to get it met. So some options of how that can be done is through reinforcement-based strategies. So reinforcement is providing desirable consequences, access to tangibles, edibles, praise, that follows a behavior to increase the likelihood that that behavior occurs again. More differential reinforcement strategies selectively reinforce desired behaviors and withhold reinforcement for undesirable or problem behaviors. So this is just a couple of different differential reinforcement strategies that are most likely used with physical aggression and self-injurious behavior. So a differential reinforcement of other behavior, or DRO, is used when an individual withholds from engaging in a problem behavior for a specified amount of time. So really what we're doing is reinforcing the absence of a problem behavior. And within the last 20 years, DROs have been the most frequently used treatments for aggression in children, youth, and adults with ASD. But something to note when using a DRO is you can inadvertently reinforce other problem behaviors that occur during the 5 minutes or 10-minute timer that you set. And so really, we're just saying they can't engage in physical aggression, but if they scream or tantrum without physical aggression, we might inadvertently reinforce that because we're not doing anything to address that particular behavior at that moment. So that's just something to note with the DRO. Differential reinforcement of alternative behavior, or DRA, is we are providing reinforcement for appropriate behaviors that serve the same function for the individual as that problem behavior. So really, we're trying to teach and reinforce more appropriate alternative behaviors to the problem behavior. So if someone becomes aggressive to try to escape a task demand, we will provide reinforcement if instead they can use some kind of a functional communication response through PECS, an AAC device, verbally, sign language, to instead say, I need a break to escape the task demand. And then the last one on here, differential reinforcement of incompatible behavior, or DRI, is when we are reinforcing appropriate behavior that, again, serves the same function of the problem behavior, but which are incompatible with the problem behavior. This means that you can't simultaneously do the appropriate behavior at the same time as the problem behavior. So if someone engages in self-injurious behavior to escape non-preferred sensory experiences like loud noises, we would provide reinforcement if instead they covered their ears, right? Because if you're covering your ears with safe hands to block out the sound, you can't also engage in headbanging because your hands are occupied. So it's incompatible, the two behaviors. We also have extinction-based strategies. So an extinction-based procedure reinforces consequences that previously maintained the problem behavior once it stopped. So we're removing that motivation for them to continue to do it. So if self-injurious behavior had been maintained by gaining social attention from others, what we're going to want to do is withdraw attention from that individual when they engage in the self-injurious behavior to reduce the problem behavior. If, for example, self-injurious behavior was maintained by escaping demands, we're going to continually present the demands despite the presentation or use of self-injurious behavior. When doing extinction-based strategies, we really need to make sure we are implementing it with safety in mind. So it needs to be done in a treatment setting, in a clinical setting, where there is protective personal equipment, chest guards, arm guards, things that protect the individual who's going in. Also to make sure the individual with autism is not going to be able to hurt themselves if they're engaging in significant self-injurious behavior if we're ignoring it. We also want to make sure that there's nothing that can be easily thrown. So we're really being mindful of that because with an extinction-based strategy, we always have the potential for there to be what's called an extinction burst. And with an extinction burst, behaviors increase, or the severity of behaviors increase of that problem behavior before they go down. And so in that sense, it's almost like going through a Rolodex of all the behaviors to see if a bigger behavior or a bolder behavior will get someone's attention or help me escape this demand. And so once we are implementing withdrawal of attention, we need to maintain our withdrawal of attention until the behavior stops. Because if we give the attention for a bigger behavior, it is just reinforcing, you just do a bigger behavior and I give you your attention. So that is definitely something that's typically these behaviors or extinction-based strategies are only done under clinic settings to make sure they're monitored. We also use functional communication training, or FCT, because this teaches to appropriately request desirable consequences by reducing inappropriate behaviors. So we do this by teaching an appropriate response, either through something like using an AAC device, PECS, vocal responses, sign language. So they are going to do that instead of engage in the problem behavior. And once they've learned this alternative communication method, we really want to make sure we're reinforcing the use of the new communication strategy immediately and consistently, and that they are getting the thing they asked for. So if they ask for a break, it needs to be immediate praise and they get that break if they use that appropriate functional communication response. Is that way they understand that what they're doing is getting them the thing that they're asking for. And then there are times when the strategies I just went over alone aren't enough to produce differences or reductions in self-injurious behavior or aggression, and further treatment add-ons such as punishment-based strategies need to be added. And so punishment involves applying or removing stimuli to decrease the likelihood that a particular behavior occurs in the future. And these are often needed in situations where what is reinforcing or maintaining a problem behavior, either we can't really clearly identify it, or when the variables can't be easily controlled. So there's something that we can't do to really control them from happening. And we always want to make sure any punishment-based strategies are used under the guidance of trained professionals, and that they're part of a larger individualized plan that includes the positive behavior support and prevention strategies that I just went over. It should never just be punishment-based strategies, because if we're only doing this to decrease the likelihood of a behavior, we're doing nothing to increase positive behaviors. So some punishment-based strategies, and this is just in case anyone does seek out treatment to give an idea of what could be used, are response reduction techniques. And so what we're doing here is we're trying to reduce the frequency of problem behaviors by removing access to a preferred item or privilege after the behavior occurs to decrease the or discourage the repetition of it. So we might use something called a response cost system, where you remove either tokens or points immediately following a behavior. And so then pairing that when there is not the behavior with reinforcement. So they're gaining reinforcement, but there's also the option that it could be lost. And really want to make sure those are used in combination. And then there is the application of negative stimuli sometimes used. So this is decreasing the frequency of problem behaviors by adding something like a water mist or aversive odor if a problem behavior occurs. And then if behaviors are a safety concern to others or an individual, then manual or mechanical restraints might be used. So a manual restraint could be other people doing a hold on them, so using physical pressure or contact to help restrain the individual so that way injury doesn't occur to others. Mechanical restraint is more using material or equipment, so using splints to ensure that headbanging can't occur, or a padded helmet to ensure that there's no injury if headbanging does occur. And then there's times where Jason will talk about next that all of these strategies may be used, and we might also need to add in additional medication strategies if needed. This is just a list of some treatment facilities that specialize in providing variations of the different types of treatment components that I just described for individuals with autism who have more severe problem behaviors. So just wanted to provide this because it is a more specialized area of treatment. And so it is hard sometimes to know where to look or where to go. Like Cynthia said, it's not always a path that's carved out, and you want to make sure that you're finding the individual that can help most. So just providing this as a reference point.
Trying to hand over control of the slides here. We're in good shape. Okay. All right. Good evening, everyone. Thanks again for being with us tonight. Thank you to Stephanie and Cynthia for your introductions. My name is Jason Sarte. I'm one of the child psychiatrists here at the Child Mind Institute. I work here in the Psychopharmacology Center very closely with Stephanie, Cynthia, and the other clinicians here. I think the kind of the key takeaway from this talk is, at least when I was thinking about an important message, is that for individuals with profound autism, it really does take an interdisciplinary approach. Individuals with profound autism present with very complex needs, as we've been discussing, and the most successful management requires constant communication between families, schools, and all the clinicians involved. So it's really cool to be able to co-present with my colleagues today, because we, in day-to-day do this type of collaborative work. All right, so challenges in assessing psychiatric symptoms. As you can imagine, individuals with profound autism present with very unique challenges, which, Stephanie and Cynthia have done a great job of outlining. Many of these individuals have limited or no verbal communication, making it difficult to rely on self-reports of things like mood, anxiety, or thought disturbances. So instead, we must often depend on observable behaviors, caregiver reports, and more structured assessments. The difficulty is that misattributing problem behaviors to autism rather than co-occurring psychiatric or even medical conditions can delay appropriate treatment. So by way of example, an individual who engages in severe self-injury might have an underlying mood disorder, anxiety, pain, an unidentified infection, or something much more rare like catatonia, which we'll talk about in a few slides. Obviously, all of these things require very different management approaches. So understanding the trigger, really the root cause, is critical. And so when I'm doing a new evaluation or evaluating a patient alongside another clinician, it's really important to keep a broad differential. And, part of what I'm often doing is checking in with a pediatrician, any subspecialists who are involved, to better understand medically what's going on, because those are things that you don't want to miss. It can often contribute to behaviors. So when thinking about key psychiatric symptom areas in profound autism, I tend to think about these in 6 main buckets or clusters, which I've outlined here. And I'm going to dedicate slides to each of these to talk about treatment strategies. The first being hyperactivity, impulsivity, and inattention, very, very common in this population and frequently co-occur both with or without a formal ADHD diagnosis, although a large proportion of individuals with profound autism will end up receiving a diagnosis of ADHD as well. In terms of repetitive behaviors, this can be benign. This can include things like hand flapping or rocking. However, sometimes repetitive behaviors can escalate into more disruptive or even self-injurious behaviors like headbanging or biting oneself. So, one thing I'm clear about up front with parents is that, as Stephanie and Cynthia alluded to, repetitive behaviors aren't in and of themselves always a target for treatment, but they do become a target for treatment when the behaviors are disruptive or when they become dangerous to the child or to others around them. And so that's when we may need to consider strategies like medication. Aggression and irritability, very, very common in this population, can range from verbal meltdowns to physical aggression. Anxiety and mood disturbances, also common, but unfortunately frequently underdiagnosed, especially in nonverbal individuals. Part of the reason is because these emotions may manifest less as overt sadness or worry, and instead as increased irritability or refusal behaviors or even new onset aggression. And so in individuals with profound autism, the picture of anxiety or depression may be a little bit different than we otherwise used to seeing. Sleep disturbances are also quite common. I would say more the rule than the exception in new evals I do. And it's often one of the most debilitating symptoms that families come in with. And so that's something that we also need to pay close attention to managing throughout the process. And then finally, I did want to talk a little bit about catatonia. It's rare, but it is more common in profound autism. Catatonia is a neuropsychiatric syndrome that's characterized by motor abnormalities. And some studies suggest that up to 17% of individuals with autism will develop catatonia-like symptoms. And on a future slide, I'll kind of go through what that looks like and how it's treated. Okay. So to focus first on hyperactivity, impulsivity, and inattention, like I said, very, very common in this population. And these behaviors can present as constant movement, difficulty staying seated, or something more dangerous like impulsively running into the street without warning. It's important to know that sensory-seeking behaviors can also contribute, particularly if individual is trying to meet sensory needs. So we have to really pay attention again to function of the behaviors. When I'm thinking about medication management for ADHD symptoms, let's forward it. When I'm thinking about managing these types of symptoms with medication, really what I'm going for are stimulant and non-stimulant medications, which we use for ADHD. It can be a little tricky in individuals with autism because there tend to be increased risk of side effects. So stimulants can be profoundly helpful for inattention and impulsivity, but we often do need to be more careful about dosing. Duration can be an issue. So some of the longer acting agents can contribute to sleep problems. We have to be careful about that. And so I do find that in a lot of my patients with more severe autism, having a non-stimulant on board ends up being very helpful, either as on its own, so as a monotherapy, or in combination with a stimulant. And the reason I like to use a combination approach in a lot of these patients is kind of threefold. So number one, non-stimulant medications like clonidine, guanfacine, atomoxetine, we find that they can actually help augment the effect of the stimulant. And what they can also do is they can help cover periods of the day when maybe the stimulant has worn off. So this is a common conundrum, right, where the stimulant might work very well for most of the day, but then you sort of have that 4 to 5 to 6 p.m. window and maybe symptoms start to reemerge. That can be an opportunity to consider adding on a non-stimulant medication, which can sort of help cover the rest of the day. Additionally, I find that non-stimulants can help mitigate some of the side effects of stimulants. So whereas in some individuals, especially with more severe autism, we find maybe some worsening irritability on a stimulant medication, a non-stimulant can help calm some of that down. And they tend to be a little bit more calming. They can help promote sleep. So they're a good option when nighttime symptoms are difficult or there's insomnia going on. And then in doing all of this, I tend to find that having a non-stimulant on board may also help lower the dose that we would need of the stimulant ordinarily. So because it's sort of augmenting the effect of the stimulant, a combination approach lets us sometimes get away with lower doses of both. So in terms of repetitive behaviors and self-injury, as you know, hallmark symptoms of autism and can serve as coping mechanisms for sensory dysregulation or anxiety. Like I said earlier, we don't necessarily want to treat every repetitive behavior, especially if it's serving a self-soothing function. A lot of these behaviors can be used to help mitigate anxiety symptoms. And so we want to be very careful about being intentional about what behaviors we're treating. When the behaviors become very disruptive, certainly if they involve self-injury or harming others, things like headbanging or biting, that often indicates something more severe, maybe pain, maybe underlying anxiety, maybe underlying mood symptoms that we need to focus on. Treatment, of course, depends on the underlying cause, right? So anxiety-related repetitive behaviors or behaviors that might look more like classic OCD, we might look to medications like SSRIs, such as Prozac, sertraline, Lexapro. When behaviors are very severe and involve self-harm, we might turn to antipsychotic medications like aripiprazole or risperidone. But of course, all the while, we're being intentional about looking also into sensory-based interventions. So things like weighted blankets, noise-canceling headphones. Sometimes by reducing environmental triggers, we can also help reduce the dose of medication that's ultimately needed. I did want to include a little bit here about N-acetylcysteine or NAC. This is a supplement that can be purchased over the counter, and it's something that I'm increasingly recommending for my patients with more severe autism and repetitive behaviors, because there is some emerging evidence that this can help actually reduce the severity and frequency of repetitive behaviors. The data isn't as strong as for some of the other medications we use in autistic patients, but there is, like I said, increasing data that this can be effective. So it is something that I often will recommend as an augmentation to medications or to behavioral strategies for children. Stephanie did a great presentation on irritability and aggression and how to manage that behaviorally. That's always the first thing we try. We want to make sure that we're addressing sensory issues. We want to make modifications in the environment as needed. We want to look at underlying medical issues. Possibly constipation is one that often comes up and can contribute to aggressive behaviors. Unidentified infections like ear infections or UTIs. These are really important things to rule out before going straight for medications such as risperidone or Abilify, both of which can be incredibly effective, and both of which actually carry FDA approvals for irritability and aggression in children with autism. But again, they're not without side effects. And so we always want to make sure that we've kind of exhausted all of the non-pharmacological approaches to managing severe and aggressive behaviors before turning to a medication. I do like to start with Abilify or risperidone just because they do have FDA approvals. For more complex cases, perhaps cases that haven't responded as well to antipsychotics, I do sometimes use mood stabilizers. There's less evidence for these agents, but they can work well. This would include medications like Depakote or lithium, for example. Regarding anxiety and depression, so this is admittedly pretty difficult to identify, especially in a child who is less verbal. And for that reason, unfortunately, anxiety and depression are frequently underdiagnosed in profound autism. Instead of typical presentations like sadness or worry, we might see increased irritability or refusal behaviors or even new aggression, right? That's always on the differential when we're seeing a new behavior. There is some data that shows that in children with ASD, rates of depression fall anywhere between 1 and 10% as diagnosed by parent report, but then subsyndromal depression rates can be much higher. So this really is not a negligible percentage of patients who will ultimately develop symptoms of anxiety or depression. Some data suggest that 40 to 50%, if not more, will develop symptoms of anxiety at some point. So we really do need to be on the lookout for this. And, as I mentioned in the previous few slides, we're always looking for triggers. And if there are non-pharmacological approaches to managing anxiety or mood symptoms, we always go for those first. Modifying the environment, making sure that sensory overload isn't an issue. When we feel that we have a good handle on those factors and we're still seeing symptoms, then again, that's when I would turn to medications such as SSRIs. We do sometimes use non-SSRI medications for anxiety, such as buspirone. Antihistamine-based medications can be helpful in some individuals. That would be medications like hydroxyzine or Benadryl. Benzodiazepines, on occasion, are something I will use. I put stars next to antihistamines and benzos just because we have to be very careful, especially in children with autism, because there are some children who will have what's called a paradoxical reaction to those agents, meaning that they're supposed to be calming, but in some individuals, they can actually cause worsened agitation and aggression. And so that's something that I always warn parents about if we're going to try one of these medications. And I always tell parents to, call me immediately and to stop the medication if they find that it is having the opposite of intended effect, because it can happen. And does tend to be more common the more severe the presentation of autism is. Sleep disturbances, very common as well, can range from difficulty falling asleep to frequent awakening too early, which can then lead to a lot of daytime problems, right? So having a poor night of sleep will definitely contribute to things like daytime fatigue, increased irritability, and it can be this vicious cycle where daytime behavior starts to deteriorate. It can be more and more difficult to get kids to go to bed, which then leads into more daytime challenges, the less sleep or the less high quality sleep the child is getting. When I'm looking at sleep problems, I, again, always want to look for something underlying. So we do know that even in the absence of a comorbid condition, individuals on the spectrum, more often than neurotypical populations, struggle with sleep. And we think it has something to do with irregular melatonin production. But again, I'm always looking for things like anxiety. I want to look for medical etiologies, discomfort due to acid reflux. I'm always asking about snoring or apneas, because those might be cases where if there's a concern for sleep apnea, then I would want to refer for a sleep study pretty early on. It's very interesting, actually. Untreated sleep apnea in children can often mimic ADHD-like symptoms. And so if I'm hearing about sleep disturbances, especially chronic sleep disturbances, and also hearing that inattention, hyperactivity are big problems, I'm doing a very careful sleep history. And in those cases, a much lower threshold to refer to a sleep specialist to get a sleep study. In terms of treating sleep disturbances, again, behavioral modifications are always the most important. I talk to parents a lot about sleep hygiene, and what that includes is regular sleep schedule, wind down routine, trying to get kids to wake up around the same time every day, even on the weekends. I really talk a lot with families about how circadian rhythm works and how the brain really thrives on routine. And the more of a routine we can establish, the better sleep ends up being. Lower hanging fruit these days, especially screen time. I'm really strict with families about cutting out screen time at least an hour or two before bed. We do know that the blue light from screens can really affect the quality of sleep and contribute to insomnia. And so these are things that I'm always counseling families about. That being said, a lot of individuals will benefit from some medication. Melatonin tends to be the first line for me. It is the most well studied in the autistic population and relatively well tolerated by most kids. Sometimes it can lead to some morning grogginess, but often this goes away with time. In cases that don't respond to melatonin or behavioral interventions, I might use medications like clonidine or even trazodone, both of which are stronger and definitely would not be first line, but can also be very effective for insomnia. Finally, I did want to mention catatonia. This is much rarer than the other symptom clusters I mentioned, but it is something that as a psychiatrist, I'm always looking out for, especially if I'm seeing motor symptoms, more sort of neurological symptoms, or sudden changes or regressions. So really, catatonia can look like a lot of different things. The classic presentation of catatonia would be motor rigidity, slowing in speech, or just overall decreased responsiveness. It could be challenging with catatonia, especially in severe autism, is that there is an agitated presentation of catatonia. And sometimes, if I'm without a clear trigger, seeing an abrupt increase in aggression, I do always in the back of my mind want to make sure that catatonia isn't a part of the picture. I tend to find in the data support that this is more common in individuals who are on antipsychotic medications. So being on medications like risperidone and Abilify, especially at higher doses, increases the risk for developing catatonia. This is something that needs to be treated pretty expeditiously if it's diagnosed. And the gold standard treatment for catatonia is benzodiazepines, and in very severe cases, electroconvulsive therapy has been effective. But this is something that obviously would have to happen in an inpatient setting. I included on this slide some of the more common side effects that we see with psychiatric medications. This is not an exhaustive list, but it's just kind of the most common side effects we see. I think really the takeaway that I want to give is that individuals who are on the spectrum, and especially individuals with more severe presentations of autism, tend to be more sensitive to medication side effects. And I think it's really multifactorial. Number one is that there are different brain development and neurotransmitter systems that are likely contributing. But then the other contributor is the fact that, again, there's often difficulty in self-reporting symptoms. So for nonverbal or minimally verbal individuals, they may not be able to say, I feel jittery, or I feel too tired, or I'm feeling sick. And so side effects like sedation or appetite suppression may not show up directly because patient can't always report these. So we often do have to rely on caregiver reports who might notice changes like eating less at meals or becoming more agitated during certain times of the day, maybe appearing unusually drowsy or more withdrawn. And that can help us to suss out, is this a medication side effect or is this a new symptom developing? But it can be really difficult to get a sense of side effects in some cases. Cynthia did an awesome job of kind of talking about medications, or rather medical issues that are comorbid in profound autism. So to just kind of expand on her introduction to that, we do see medical challenges very commonly in this population. And so much of the work that I do is making sure that we are staying on top of the child's medical issues. So to start with GI disorders, this is incredibly common in autistic patients. Constipation affects 70+% of individuals with profound autism at some point. In nonverbal individuals, that discomfort might manifest as irritability, aggression, or even self-injury, rather than the person telling us they feel constipated. And to assess for this, it's helpful for caregivers to monitor stool frequency, consistency, whether there are signs like straining or bloating. And then management can include dietary interventions like increasing fiber and fluids, sometimes over-the-counter medications like Miralax, or in more severe cases, I might refer to a gastroenterologist to rule out underlying conditions. Next is sleep disturbances, which we talked a bit about earlier. I think the main takeaway for sleep disorders is that I'm always wanting to make sure that there isn't an indication for a sleep study. So again, I have a lower threshold for referring for a sleep study if there are signs of sleep apnea. So these would be things like snoring, waking up with headaches, or waking up feeling not well rested, symptoms of hyperactivity or inattention that aren't clearly related to an ADHD diagnosis. And sometimes parents or caregivers might actually witness overt pauses in breathing, which would definitely prompt a referral to a sleep specialist. And epilepsy is unfortunately quite common in autism. The data show that up to 30% of individuals with autism will have seizures at some point. And so this is also something that I assess very carefully for in a new evaluation, and something I'm constantly looking out for throughout treatment, especially because, again, seizures don't always look so classic in individuals with autism. Sometimes sudden behavioral regression, new onset aggression, or even brief periods of inattention. Parents might describe these as staring spells, rhythmic movements, sudden changes in mood or energy level. These can all be red flags for a possible seizure disorder. And so whenever I'm hearing symptoms like this, that always alerts me to, consider referring to neurology to get an EEG, because if there is seizures going on, it's very important, obviously, to get those treated. And very often, if seizures were at least partially contributing to behaviors, then adequately treating the seizures with anti-epileptic medications can actually help improve behaviors as well. Pica is the compulsive ingestion of non-food items, which is another serious concern that comes up in profound autism. Caregivers might notice missing household items, unexplained GI symptoms, or even symptoms of lead toxicity, depending on what's being ingested. And so to manage this, environmental modifications are very important. Blocking away hazardous materials and providing safer sensory alternatives like chewable jewelry, for example. I tend to recommend lab work if I'm concerned about pica. So sometimes pica can indicate deficiency in iron, and so that's something that I will usually get upfront if that's part of the clinical picture. And then finally, unaddressed vision or hearing impairments, very common and can be contributors to behavioral issues. Caregivers might notice avoidance of social interaction or squinting, unusual reactions to loud sounds. And so I usually like to be closely connected with audiology and ophthalmology to make sure that vision and hearing are checked at baseline, and every so often to make sure that this is not a contributor to problem behaviors. I did want to talk briefly about puberty because this is a question that often comes up in my pre-adolescent or adolescent patients who are on the spectrum. So as you would expect, puberty brings its own set of challenges, right? Hormonal shifts during adolescence can amplify aggression, mood instability, and irritability, and especially in nonverbal individuals who might struggle to express what they're feeling. So for females, menstrual pain often presents as increased irritability or even self-injury, and managing this might involve tracking behavioral changes around the menstrual cycle, and in some cases, considering options like NSAIDs or hormonal treatments. And so for these cases, collaboration with a gynecologist might be helpful. In some cases, we can see precocious puberty where changes happen earlier than expected. This understandably can be very overwhelming for both the child and their caregivers. Nonverbal children might show changes in mood, sudden aggression, or physical growth patterns that seem very out of sync with their age. And so these cases might involve getting an endocrinologist on board as well to address hormonal dysregulation and to manage those symptoms. So I wanted to end on a little bit about genetics. There's so much I could say about this. Cynthia did talk briefly about how in individuals with profound autism, there's much more common for there to be an underlying genetic contributor. And so what I often will recommend for families, especially with more severe autism presentation, is genetic testing. And the reason why is because we do tend to find that if there is a genetic syndrome underlying the autism, then there can often be medical conditions or medical problems that are associated with that same syndrome. So I included some examples here of key genetic syndromes that we see that are strongly associated with autism spectrum disorder. We do see lots of neurological issues in many of these syndromes, so things like seizures or brain masses. We also can sometimes see cardiac problems. And so, if we were to diagnose a genetic syndrome, it's important that child is getting routine surveillance visits with cardiology, with neurology. And so sometimes this might involve getting annual echocardiograms or EKGs to make sure that heart is healthy, right? So, when parents ask me about, why get genetic testing, it really is because we want to make sure that there aren't other medical comorbidities that might be involved with a genetic syndrome. And then there's also the family planning component as well. So testing and diagnosis does allow for appropriate screening for and management of related medical conditions, and also allows for screening for sort of the risk of having a child in the future who might struggle with similar condition. So thank you all again for being here, for inviting us to speak with you tonight. There is a QR code here if you'd like to take just a minute or two to give us some feedback. We hope you enjoyed this presentation, hope that it was helpful. We wanted to leave at least some time at the end here for some questions. So I think I'm going to turn this now back over to Jackie to run our Q&A session.
Hi, thank you very much for such a robust and informative webinar. I'm sure it will quickly be a favorite within the community. And I loved how this information can apply broadly for parents, for providers, even I was thinking educators, and how important it is to have this information. So thank you very much. We do have some questions in the Q&A. They are starting to pop in more and more. I want to just start off with one question real quick, because I am seeing you had explained the importance of having the ABA component first before adding in the psychiatry. However, I wanted to ask you about, you mentioned with catatonia, the need for a very fast intervention with psychiatry for catatonia. So how can the BCBA really flag that so that it's not taking the time for the prolonged FBA and the different types of treatment modalities that are being tried before we get to that point where, oh, maybe we need psychiatry added in, but by that point, perhaps it's malignant at that point. So how does the BCBA determine that?
I can start just from my perspective in psychiatry. I think that BCBAs are very well trained to look at not just behaviorally what's going on, but also sort of physical manifestations. I always recommend to non-psychiatric clinicians, if there's ever any doubt about what is driving the symptom, that it's always okay to refer earlier rather than later to psychiatry. In fact, a lot of the evals I've done recently have been sort of, like in the middle of getting an evaluation with maybe the Autism Center. But there is clearly a concern for potential medical contributors or potentially the need for medication more quickly, even while more of a diagnostic is going on. So, I think that, in terms of my perspective, I tend to just say very low threshold for referring to psychiatry. I'm always happy to be involved as early as is needed. And, I just encourage all non-psychiatric clinicians working with this population to, not hesitate to reach out, if not to psychiatry, to pediatrics to get a better handle on what could be going on, especially if you're noticing symptoms like, motor changes, rigidity, non-responsiveness. And again, I think we're always looking for patterns and changes, right? So I'd be less concerned about catatonia if this were, these are chronic symptoms that have been presenting for years or months. It's a little bit different if there's been an abrupt change in just a matter of days or weeks. That would maybe raise some more red flags for me that a more urgent evaluation needs to happen.
Absolutely. Thank you.
I'll just add to that, Jackie, that sometimes there are also cases where problem behaviors that you might be doing therapy for are so significant safety-wise, either for the individual or others doing treatment, that psychiatry actually is brought in early on, because we need to reduce the behavior some just to maintain safety and then work simultaneously together, especially as you're saying, because it could take a while to do the FBA and get through it and then come up with a treatment plan and try different things. So wanting to ensure safety for both the individual and the providers. So we may need to bring psychiatry in earlier on if the rates are just so high, especially when doing that FA, if it doesn't seem that treatment could commence without some additional support.
And to piggyback on that as well, when you're thinking about your initial team who's evaluating your child for autism, you want to develop that team in a way where there's somebody who's going to be able to follow the child over time. Because if they know that child so well, they're going to be able to really quickly say, like, wait, hold on, no, this is something new. This is not something that's a behavior. This might be more, this might be really due to something else, or simultaneously be able to say that behavior is likely due to, based on their age and their cognitive profile and their language profile, based on this transition that's coming up, there's a high chance that other co-occurring conditions might be coming online now, and can recommend you'll give this X number of days or weeks, or take this approach. And then if that's not working, get in to see another provider for evaluation and treatment of this. And I speak about that kind of generally because it does tend to be really different for each individual child, but somebody who knows that child really well and knows how autism presents and manifests for them will be able to really pick up on when something is atypically atypical for that child.
Great. Thank you. Thank you. So, and the next question actually kind of is similar. So does severity of the behaviors play a factor too? Because Alexander McInnes is saying that in their experience, severely aggressive behavior typically comes from something completely internal to the person with severe autism versus more triggered by things in the environment. Do you see that the difference with severity?
So there can be differences in the severity. I think it's more like the frequency of it and duration, things like that. But also when it's coming triggered from internally from someone, that could be because of an unmet need, overwhelming sensory experience. So it is still something that's going on that they may just not be able to communicate about. And that behavior is then an expression of that. So still may be an escape, like trying to escape that unmet, uncomfortable need and wanting help. So needing that support from others, but just not sure how to do it. And so we do see that. It may also be that that is a preferred sensory experience experienced or something that is internal that is experienced. So yes, it could be in both regards, that it happens more if it's more severe. And it might be internal, but it also can have other factors that when we just look at it more holistically, that we see that even if it seems internal, there could still be external factors that lead to that internal discomfort.
There's always going to be some degree of bidirectional relationship. You're never going to be able to, unless you have a person in a vacuum where they have no interaction with anything outside of themselves, you're never going to have something that is 100% internal that doesn't have some degree of maintenance or habit, behavioral pattern that has emerged in the context of whatever the environmental factors are.
The next question is, what is the prevalence of self-injury and aggression in individuals who previously did not show this behavior in childhood? And if the behavior does continue past 3 years, what are the chances it will persist throughout the individual's lifespan?
So those rates of prevalence are more lifetime rates. So just what the likelihood it could happen at any point in an individual's life. So for some, and right, like the research is all different, depending when they did it and with who at what time. So some could be younger kids. It could have been adults that they're doing research with to see like behaviors previously in their life. So really that is just like the lifetime expectancy that we would see that behavior. If it is persisting for more than 3 years, then it's likely to persist longer without intervention.
And I think we don't have as much predictors of young children who do not have any behavioral challenges. What's the percentage of them having behavior challenges at a later point in time? But we do know that one of the biggest predictors of later problem behaviors is having early aggressive, disruptive problem behaviors, particularly when those go untreated. Now, even with those kids who do get treatment and support for those behaviors, for some kids, it is more of a chronic problem for them. And so it's not that we don't also have a perfect way of fixing everything for a child. So that's where we have to kind of take that approach where we're trying one thing, and if that's not working, okay, now we're going on to the next piece and trying to really help build up those skills over time in efforts to reduce the problem behaviors.
And I think that's important to just highlight what Cynthia said. It's to reduce, never to eliminate, because we can't promise that a behavior will never occur again. We're trying to reduce it and make it more manageable. So it's not that self-injurious behavior will never occur again. It's just getting to a more manageable or a less frequent in place where it's not going to likely cause injury to that individual, or more manageable for those around the individual.
I personally definitely have experience with it's not possible to eliminate, but definitely reduce. So, I really appreciate that you provided the resources as far as different treatment options for this level of severity, because we get that question all the time, at least a few times every week. And so that's a really great slide. But there was a question in the Q&A asking if you are aware of any treatment facilities in Canada.
So I'm not familiar. We are on the East Coast, so those were all treatment facilities on the East Coast that I'm most familiar with, or that we typically refer our families to, because some are still far from us in New York, but are reasonable for families to at least try to get to, with like Ronald McDonald services and things like that. So I'm not as familiar, unfortunately. Sorry about any in Canada.
Okay, so there was another question of how do you diagnose for catatonia? I guess which screening system are you using? Or are you using a combination of Canner and Bush-Francis? What is your preference for diagnosis for catatonia?
Sure, yeah. I mean, it's ultimately a clinical diagnosis, so we can use measures like the Bush-Francis to assist in that and sort of getting a sense of severity and sort of the likelihood of it. I've definitely used Bush-Francis as more of a guide, but there really isn't any one tool that is needed to diagnose catatonia. Ultimately, is clinical. What's interesting is this isn't something we necessarily do in an outpatient setting. But at times in an inpatient setting, if there is a question of catatonia in a much more controlled and safe environment, there is what's called like an Ativan challenge or a lorazepam challenge. And what actually happens is it's sort of the treatment is also revealing the diagnosis, where if a clinician has a suspicion that there is some catatonia involved, giving a dose of IV Ativan should actually quite immediately improve symptoms. So that can also be a way to quickly lead to that diagnosis. But it definitely is trickier on an outpatient basis. I think that much more mild forms of catatonia can be missed because as I mentioned, it really can look like a lot of other things, right? And so that's why I think really in all of our work, we have to always be really willing to pivot and sort of change our assessment because obviously individuals change and environments change and that nothing is static. And so maybe, what starts out as more of a problem of, inattention might then develop into more of a problem of aggression. So we really do have to be willing to kind of pivot when needed.
Wait, let's take a few more questions here. What is the recommended dose of NAC? You had mentioned using it over the counter.
Sure. Yeah. So obviously I would, check with your own provider for your specific child. But generally the range I use is anywhere between 1,200 milligrams to 2,400 milligrams. That's generally what's most studied. And usually that's in divided doses. So I like to use capsules that are 600 milligrams each. The nice thing is that these capsules can be opened and sprinkled onto food or into a liquid in individuals who have trouble swallowing pills. And so generally I would aim for anywhere from 600 twice a day to 1,200 twice a day. But obviously sort of the rate of titration and whether or not that's appropriate for your child, I would defer to your own physician.
Okay, I'm going to combine two and stick with you, Jason, for a minute, because there's two questions in here on more medications. One is, do you have any current info on the success of leucovorin in the increasing expressive language? And the second is, what do you think about the use of SNRIs like desvenlafaxine?
Yeah. So to address the first question, I don't unfortunately have much data on leucovorin. It's something that I'd be interested to look more into. It's certainly not something that I use in my clinical practice or that has sort of an FDA approval. Regarding SNRIs, they're definitely medications that we can and sometimes do use. I tend to find that SSRIs are a little bit better tolerated from a side effect profile. SNRIs in a lot of individuals can be a little bit overactivating. We do have to monitor things like blood pressure and heart rate because they can cause slight increases in those parameters. I would say nothing is absolute. So if I were working with a patient who, we trialed 2-3 different SSRIs, and it's very clear that anxiety or mood is part of the problem, and those agents aren't working, then certainly SNRIs are medications that could be considered. I think with desvenlafaxine specifically, I'd be less inclined to use that in a child just because we don't have as many studies in the use of that particular SNRI in kids. But the two that I will often use are venlafaxine or duloxetine. Those would be the two that I would go for first.
Yeah. So there's a question in here, since going through puberty, and she said that her son had a severe increase in self-injury and aggressive behaviors, property destruction, as well as increase in sensory sensitivity to noises. Any suggestions on how to help with sensory sensitivity other than headphones? This might be one for Stephanie, maybe.
So some if possible, and I know, right, like these are some of what Cynthia was saying, like we're not in a vacuum, but when possible, environmental modifications, if we can do things to try to eliminate the sounds that we know may cause some of the behaviors, trying to do things like that. Trying to for little bits of time tolerating, giving rewards or access to preferred items if they're able to tolerate that, able to use the noise canceling headphones appropriately are things that we're going to want to really try to focus on.
Right. Great. So they're asking if there'll be a copy of the slides available for anyone. We are recording this, so people will be able to watch the webinar with all of the slides again. It'll be available on our YouTube. We'll post it across socials. But how about the slides?
Yes, I can answer. The slides will be available if you fill out the post-event survey, which is linked in the chat. We had a QR code, but that goes right to the chat, and I can send it one more time.
And that everyone is Annie. She's been helping behind the scenes with the team here. She's been really wonderful. So, okay, so everyone, we'll take one more question. If the child is self-injurious and is hurting his head, what procedures or evaluations you would do to recommend if the person may have severe head injury? What doctors would you suggest? A neurologist or psychiatrist or tests?
Yeah, so definitely wanting to consult with neurology to see the extent of the damage due to the self-injurious behavior. And then that is likely, if there is damage done because of the self-injury, going to be one of those instances when more of a restraint is going to be used. So then getting fitted for a helmet or something like that to prevent further injury. And then that medical provider would indicate what treatment might need to be done to rehab any traumatic brain injury that might have occurred due to the self-injurious behavior. So definitely wanting to start with that medical provider to see what happened, but also simultaneously getting started with a treatment provider too that can do the behavioral therapy, but wanting that medical clearance before anything else can be done. Because if there is a significant traumatic brain injury, obviously we would not do an extinction-based procedure if like they cannot have any further hits to their head. So that's information that we would have to work together for.
Wonderful. Good. Thank you very much for coming on here tonight and staying so long with us. We do still have some questions left in the chat. Is there any way that anyone with additional questions might be able to get in contact? How would you like them to do that?
I'll put an email into the chat as well.
Great. Thank you very much. And so, okay. Thank you everyone for joining us tonight. Again, we will have this up on the YouTube probably tomorrow or maybe potentially later tonight, but this has been fantastic and we are so appreciative. You're welcome back anytime. Thank you.
Thank you.